Okay, this is chapter 14 module on neurocognitive disorders. I'm going to try to make this brief and cover some of the topics that might help you if we had been meeting in person um, in class. So hope you're doing well. Hope you had a good Thanksgiving. Let's see. So with this with this chapter on neurocognitive disorders, let me make that larger. We're going to talk about delirium and then a number of other things that fall under the category of major and mild neurocognitive disorder, which used to be called dementia. The criteria for delirium is a disturbance in attention. Or you can read this. And typically, I mean, the big things I want you to know about this, I mean, it's when a person kind of loses the ability to communicate and direct their attention. I had a friend who developed this twice, once in response to a dramatic change in their electrolytes, and she was a much older person, and another when she went through a traumatic situation, and she basically was not able to conduct her life in the way she needed to do for a short period of time. And then she was, I'm talking about me, but like my friend was medicated, and that medication also created more problems with this very disorder. One of the things you'll find when you read about it is that delirium often happens with kids and older people when they undergo general anesthesia for surgery of any sort. Because you have all sorts of, obviously, dramatically impacting the neurotransmitters in the brain. But then you're going to have, someone who's going to have a difficult time communicating and being aware of where they are, orienting to what day it is, and where they're at, and who they're with. They have some memory problems and difficulty problem solving and thinking right. If you look at it, they're unable to carry out purposeful mental activity. But this cannot be explained by other major neurocognitive disorders or intoxication or poisoning. And I put up here, especially the elderly at risk after surgery. And there are degrees. I like this continuum. I'll ask about you, but this whole continuum where you go for the average person, has a degree of alertness where they can respond to a question that's asked of them and solve problems and turn their attention to this and then turn their attention to that. With delirium, it's unfocused. You go a step further and you basically have a stupor where a person is kind of like this and they're not responsive. I mean, it's just, you know what a stupor is. And then the next degree is coma. So if you think about degrees of alertness and a person's ability to interact with others, I think I like that chain of degrees there. I put up here on this slide that delirium can change quickly in terms of its severity. And the one thing that kind of is a hallmark of this are dramatic changes in sleep. So a person may not sleep very much at all, or sleep at weird times. So for the people who are living with a person who might have that delirium, becomes a challenge, especially if the person is not resting or sleeping, and you think like, oh, that's going to help them get better, but it is disturbed because of the nature of the disorder itself. Okay, the next two categories are mild and major and mild neurocognitive disorder. The committees that put together the DSM wanted to come up with this diagnostic label for a couple reasons. One is that a person can have a traumatic brain injury or a stroke and then begin to recover. And it's nice to be able to have a label that is indicative of this person appears to almost be getting better. Also, I mean, if a person is in the very early stages of something like Alzheimer's disease and it's very mild, that is fairly descriptive of what's going on. In mild neurocognitive disorder, a person can still engage in activities, but they may need some extra time to do those activities. If you look at the the major criteria for major neurocognitive disorder, what used to be called dementia, you can just read these yourself. I'm not going to read these to you on this video. One one of the things I'll draw your attention to is that the people who can identify that they are suffering from a neurocognitive disorder, obviously a clinician, a therapist, the person themselves may notice it, and also what they call an informant, or someone who knows the person really well and is able to detect a noticeable decline in functioning in all sorts of ways. And you can, again, read through this and it'll describe the sorts of problems that person may have. There are several different types of major neurocognitive disorder. So I want to highlight this in addition to the symptoms that are listed in the DSM-5. Understanding, interpreting, and responding to others is a problem. So if you're communicating with someone with a major neurocognitive disorder, you will likely notice that it takes some processing time to try to figure out exactly what you're saying and try to figure out how to respond. Again, they're using the term major neurocognitive disorders instead of dementia because young people can have that due to a brain injury. And so and the stigma associated with the term dementia and the idea that everyone is associated with just a person being older was really, it was just leading to myths about this disorder itself. So that's why they have relabeled this as major neurocognitive disorders. I put up here that also they have difficulty controlling emotions. Their judgment might be off, and as it progresses, making moral decisions can be tough. I mean, it's not only tough, they make decisions that otherwise they probably would not have made. And so we probably characterize that as also personality changes. And it's one of the difficult things about these neurocognitive disorders, especially if you've known someone with them. I know many of the students in this class have worked in assisted living residential housing type things. And I heard it once described from a spouse that she felt like her husband, like someone was coming in and taking like a piece of his brain, just a small piece every little day, and just removing a piece. And so the progression of that disorder, and that's what they call degenerative. I mean, that it progresses and progresses, sometimes very slowly, but it can then, again, have a person who may have been just a really, the person you know and love ends up having difficulty controlling their emotions. So they may be aggressive, they may be angry, they may be inappropriately sexual. They may make some moral decisions that they would not have made if they did not have that disorder. Basically, if their brain was not decaying. If you look at the distribution for like all these major neurocognitive disorders, Alzheimer's by far is the largest proportion of these. Strokes and Parkinson's, TBIs, traumatic brain injuries also account for many of those. But yeah, Alzheimer's disease is the worst. This is a note from your chapter. The delirium, I mean, when I saw this stat, I was really struck by it, but it made sense. So this is only talking about a clinical population, a population of people that have already been hospitalized for other medical issues, but up to 24% of them can have delirium. So that, again, going back to the research, is likely due to the fact that they were in the hospital for surgery anyway, underwent general anesthesia, and that contributed to their development of delirium. You look at these stats. I mean, I like the stats from the Alzheimer's Association, and they have some different numbers than what you were going to see from your book. They talk about from age 75 to 84, up to 53% of the people could have a major neurocognitive disorder. That's a lot of people in that age group. The number goes down after that because the disorders also are fatal. So they result in death. And then, so the people who survive past that age likely don't have it. Also, traumatic brain injuries typically happens more with men than women. So when we get to that one, that's a noticeable epidemiological difference there. So if you look, we're going to spend more time, as your book chapter does, with Alzheimer's disease. We already talked for about 10 minutes. I already mentioned that degenerative means it gets worse over time. The only way they can absolutely confirm that a person had Alzheimer's is through an autopsy. I mean, they obviously can have ideas. It's always great to have a baseline of how a person was functioning. And that's usually why they call in informants or people from the family or people who knew the person well. How were they doing before? How does that compare with how they're doing now? So having that baseline assessment, even having it formalized, is pretty critical. Two major etiological factors that if you have our Getty's class right now, I know she's talked about, are these beta amyloid plaques and neurofibrillary tangles. I have pictures on them in the next couple slides. These plaques are kind of like plaque on your teeth, but it's just gunk that builds up between neurons. And it builds up before the dementia signs are actually noticeable. As they increase, people start to notice some of the forgetting things and the poor performance on tasks. There's some research to indicate that there is a genetic vulnerability to it. And people who have this genetic predisposition to having less of a key protein, which destroys these plaques, are much more vulnerable. And one set of research I'll describe in a little bit when it comes to risk factors are, there have been studies, men who have this gene who makes it so they do not create this APOE protein, and if they've been depressed, are nearly 7 times more likely to develop Alzheimer's disease than people who don't have that combination, or one or the other. There appears to potentially be some environmental factors that could contribute to the development of this. Your chapter talks about lead, but also zinc. They think that that might be a contributing factor to the clumping of the plaques that happens between neurons in the brain. Within each neuron in our nervous system, there are channels through which nutrients are, basically passed back and forth within the cell itself. What happens with Alzheimer's disease, these channels get tangled, and it disrupts the flow of nutrients, and so you're going to have a warped, deformed cell. So if you look at, like, this is what the plaques look like. I just took this off the internet, obviously. Between neurons, this is what down at the bottom, a neuron with those tangles look like. It just looks shriveled. Some of the risk factors include being old, obviously. Females are more likely to have that. Current smokers. Low level of education, one thing they recommend is constant cognitive stimulation as much as you can, even at a young age, is good, along with regular aerobic exercise, any sort of physical thing that gets your heart rate up. Being of low income, being isolated and lonely are increased risks for that. I know when my dad developed Alzheimer's, he got kind of isolated because he also had hearing problems. And so it was tough for us to determine, is this because he's having problems hearing, or is he just in his own world? And so that was sometimes a challenge for us to try to figure out. If a person's had head trauma, that's a risk factor for developing Alzheimer's. And I just said this here, a history of depression along with that genetic vulnerability. This is a picture of a Alzheimer's brain versus a person with a healthy brain. And you can see the hippocampus especially is much smaller. And that brain structure is associated with memory. And I mean, you just see this death of neurons across the cortex. One of the things that we know about acetylcholine is one of those neurotransmitters that's critical for memory and body movement. These cells are dramatically damaged in the basal forebrain. I've come across warnings recently, if anybody has a vulnerability to Alzheimer's, to avoid things that block the action of acetylcholine, like Benadryl is a common drug like that. Which is strange, because I know a number of people who take that just go to sleep. And then you have damage to all these brain structures. So you can read about it in your chapter, but I mean, this is going to create problems, especially, some people in more advanced stages of Alzheimer's develop basically delusions that a spouse may be cheating on them, or that people are trying to steal their money, rob their money. And again, the person does not have the same personality that you typically knew before they were stricken with these symptoms. Treatment is difficult because the person may not understand what's going on, may not understand the requests that are being put to them, their recollection of what was just even said. I visited, I used to volunteer for hospice, and went to locked units at Lenore Assisted Living. And I'm like, why are these units locked? It's like, well, these are Alzheimer's patients that have a tendency to wander. And if they weren't kept into a locked unit, they could be wandering anywhere, not knowing who they are or where they are. You can have agitation, incontinence, I already mentioned aggression and inappropriate sexual behavior. You look at some of the treatments, your book talks a little bit more about them. I did some additional research and found the drugs they have currently are not very promising. What is promising is that they appear to be focusing on how to address those plaques and tangles in the neurons. So hopefully something will happen with that in the near future. Using behavioral treatments that don't require even communication, but just providing reinforcement for healthy behaviors and good behaviors. That appears to be a good one. And keep in mind, people who are providing the care for anyone with Alzheimer's need help. They're going to be often depressed, isolated themselves, and I actually directing them to the Alzheimer's Association webpage, I think could be a good thing, but just also lending an ear to anyone who's providing that kind of support can help a person feel less isolated. Okay. Here are a set of recommendations about how to communicate. This is one of the things that I even found useful when my dad started developing the disorder. Underlying themes: be kind. Don't try to demand and tell people what to do. Unfortunately, what I noticed in my own family, my mom got really frustrated. She was taking care of my dad and would just become short-tempered. But trying to understand the nature of this is biological. The person's not doing these things on purpose, and they need to be divert their attention, not corrected and punished for their lack of ability to think clearly. So switching from Alzheimer's disease, there is traumatic brain injury, also called TBIs. I mean, and with so many of the other things we'll talk about, stroke included, I mean, it really depends on where the damage was, how intensive it was, whether it's going to be, the symptoms are going to be temporary or permanent. Obviously, with a concussion, you have things like nausea and sometimes just a brief, immediate lack of consciousness, dizziness, confusion, and those sorts of things, sometimes headaches. So the concussion results from a significant blow to the head, and usually those symptoms are temporary. But if a person has another concussion soon after the first one, that starts to set up a chain of problems with a person's brain and lead to this condition called chronic traumatic encephalopathy. That's a mouthful to say, CTE. And that is related to depression, poor impulse control, and increased risk of dementia. Unfortunately, I did have a student once who, as a football player, underwent a number of concussions, and he was asking me about his own depression and his own inability to sleep. And I'm like, these are things related to this particular disorder, and I encouraged him to read up on it. But as far as I know at this point, not a lot can be done. They treat it typically with occupational therapy, speech therapy, and physical therapy. Strokes. A person like with like high cholesterol and high blood pressure is a more increased risk of having plaque develop in the arteries. So just like we talked about plaque in the neurons, plaque in the blood vessels. This can lead to a blood vessel bursting, which is called hemorrhage or hemorrhagic stroke, or it can just lead to a block of the blood flow. That's called an ischemic stroke. And it's because then if you can't get the oxygenated blood to the neurons, those neurons are going to die. So again, where the stroke occurs is important. If it occurs on the left side of the brain, you're going to have problems with speech and language, and problems with moving the right side of the body because there's crossover in the brain in terms of what's being controlled. If it's on the right side of the brain, it usually results in impulse control problems and some short-term memory problems. I know when my mom had a stroke, she had a few impulse control. She actually used to be very hesitant to express her anger, and she became much less hesitant after her stroke. And sometimes strokes are silent. That person, they're not so dramatic that people notice them, but these mini strokes can lead to additional deficits in functioning. These strokes can be detected using MRIs and things like that. Dementia with Lewy bodies is another type of major neurocognitive disorder. And these are just irregular proteins that develop in the cell bodies and sometimes the nucleus of neurons. The problem with this is that people die usually within 8 years of being diagnosed with this. Robin Williams, a famous comedian and actor, knew this was the case for him. And I think that's one of the reasons that he committed suicide. Parkinson's disease, I'm looking at the time, trying to figure out how much time that I've already spent 20 minutes. So I'm going to try to just identify this quickly. You've heard of this, I'm sure. Muhammad Ali, Michael J. Fox, famous cases with this disorder. Tremors. You have death of neurons in the basal ganglia that are rich in dopamine that control movement. Basically they use drugs like L-Dopa, which increase dopamine in the brain. Unfortunately, we know that's also associated with schizophrenia. So a person with high doses of L-Dopa can develop hallucinations and things like that. So it has to be monitored closely. One friend of mine who had this, has this disorder, had like some just very small wire electrodes placed in the basal ganglia, and the stimulation, electrical artificial stimulation, basically acted as action potentials to keep some of those neurons still functioning and living, which helped his movement and his thought processes. This is what you see in a healthy brain, someone with Parkinson's before the symptoms, and then you see how, again, obviously the hot red areas are the neurons firing a lot, and you see just that's not happening so much. HIV infection, the only real thing I want to say about that is there are a lot of good drugs to prevent HIV infection right now. Right now, the name of the drug is slipping my mind. Just in researching this presentation and the notes I prepared for you, I came across this idea that even if the person is on drugs that are keeping the symptoms of HIV or they're undetectable in their viral load, can still develop neurocognitive problems. And so that was something I did not know. And that's something, if you know a person who's HIV positive, to be aware of. Overall, many treatments have been mentioned already. I would encourage, again, that physical exercise, any cognitive stimulation at all, continuing throughout life. Don't get bored. Being socially connected, that is huge. The research is enormous on that. Breaking things down into small tasks. I gave you a video to watch for your video quiz, which just addresses one part of that. There are a lot of videos online that you can share with family members if they're dealing with someone with symptoms of major neurocognitive disorders. Making things clear, clutter-free, simple in life, and scheduled helps with these major neurocognitive disorders. So with that, that was about 23 minutes. I hope that helped out, and I wish you the best on the test for this. Take care.